All right, good morning. Thanks again for having me. I'm Felipe Teran. I'm an emergency medicine physician and currently ultrasound fellow at Sinai. I've been interested in cardiac arrest ultrasound since early in residency. It was the reason why I originally became interested in point-of-care ultrasound. So I started sort of studying and dedicating myself to this during residency, and then it's been my sort of topic, sort of niche during fellowship. You might be wondering, why we're going to talk about cardiac arrest ultrasound. It's a topic that most of you as emergency physicians at this point are familiar with, that you probably and hopefully do on a regular basis. The main reason why I think it's important to discuss point-of-care ultrasound today is because it is one of the most promising tools that we have for the management of cardiac arrest. How's that? So traditionally, we've been looking mostly, our attention in terms of the research and the guidelines in cardiac arrest has been focusing on shockable rhythms. That's been the case for the past 20, 30 years. And there's a good reason for that. VFib and pulses VTAC have significantly much better chances of survival, much better survival rates and good functional outcomes compared to PEA and asystole. And therefore, it makes sense that is what has received more attention: bystander CPR, early defibrillation. But the truth is, over the past 20 years now, both according to data from the United States, from the American Heart Association Get With The Guidelines registry that collects data from over 700 hospitals across the country, and also from large resuscitation European databases, we know that the rates of PEA and asystole arrest have been readily increasing in regards to the total number of cardiac arrests. So as a presenting rhythm, it's becoming more and more likely that you will find a patient with PEA or asystole. It's always been more likely compared to BFib, but the rates of ventricular fibrillation specifically have been decreasing over the past decade. So chances are that in the future, in the next decade, you will be facing PEA arrest or asystolic arrest in most of the cases that you'll treat in the emergency department, as well as in-hospital cardiac arrest. We can summarize the rationale of using point-of-care ultrasound in cardiac arrest in three aspects, three main applications: as a diagnostic tool, as a prognostic tool, and the third, which is what I think is most promising, is a quality enhancer. Let's start with the one that I think most of you are familiar with, which is diagnostic. Diagnostic, the use of point-of-care ultrasound during cardiac arrest allows us to identify that the patient is actually in cardiac arrest. It might sound silly, but as I'm going to show you in the next few slides, that actually can be an issue sometimes. It allows us to assess whether a patient is actually generating any meaningful cardiac output. And finally, it allows us to identify those so-called reversible etiologies. The third line here is the one that most people are familiar with, and this is also the aspect that the guidelines refer to the most, the so-called HSNT, especially in the case of PEA arrest. So the decision to start CPR in a patient, unresponsive patient, either in hospital or out of hospital cardiac arrest, is based on the presence, on the absence of a central pulse, correct? So we have an unresponsive patient, we check for a central pulse, and then we call it cardiac arrest. We start CPR. But there's a few problems with this, and there's good data to support the fact that there's a few problems with this. The fact that the decision to start CPR based on either radial central pulse, femoral, or carotid pulse is that there's good literature supporting the fact that it's the search for the palpation of the central pulse with our fingers is simply not sensitive enough. It's not specific enough. And finally, there is literature showing that there's a significant variability among providers. Providers don't don't always agree on whether they're feeling or not feeling a pulse. And this can be an issue. This is an Australian study that looked at the ability of providers to detect a central pulse in pediatric patients in an ICU. They had pediatric patients that had cardiothoracic surgery and were recovering in the CTICU. All of them had LVOTs implanted. So you know, patients that go into cardiac surgery, many of them need to be supported with a mechanical support when they come out of surgery and come out of bypass until their heart sort of restarts by itself and shows enough native function to run on its own. In this study, they brought in providers and they were blinded to the hemodynamic data showing in the monitors of these patients. And the patients were at different stages of recovery. So they had different degrees of native cardiac function. And as you know, when patients have a mechanical support device that has continuous flow, as is the case with most newer devices, they don't have a pulse. So patients are coming right out of the OR with no heart function, would have no pulse, and then those at the end of or towards the later part of the recovery would already have somewhat normal pulse. And then there will be some patients in the middle that were starting to generate their normal cardiac activity and therefore had sort of a weak pulse, if you want. So this was a model to represent what actually happens in cardiac arrest. And what they found here was that 78% of the providers in this group, only 78%, were able to identify successfully the presence or absence of a pulse in these patients. The sensitivity in this study was 86% and the specificity 64%. So not really great numbers. Another study performed in adult patients. This was in patients that had CABG surgery, so were supported with cardiopulmonary bypass, doing their surgery in the OR, and they brought in providers and they asked them to feel pulse. Same thing, during the 3 different stages. When you go into bypass, at the beginning you have your normal pulse. When you go in bypass, there's a transition, what is called partial bypass, where you're partially supported by bypass, and at that point some of them had most of them had a weaker pulse, and then when they're supported fully by bypass and they're asystolic, then they won't have a pulse. In this case, only 10% of the patients with no carotid pulse doing the bypass were not actually recognized by the providers as to be pulseless. So the specificity in this study was only 55%. And I don't know about you, but I don't know how most of your patients in cardiac arrest look like. But unfortunately, many of the ones that I managed look like the patient in the picture. In fact, it was a patient just like this one that activated what's called Team 7000, our in-hospital cardiac arrest code, when I was working in the ER, and he was in CT in the first floor, so it's the ER that we respond to. So as I always do, I took my ultrasound machine and run to the arrest. The nurses and the rest of the team were bringing the rest of the equipment. As soon as we arrived there, multiple providers were trying to detect a pulse, while others were trying to connect the patient to a monitor. While this is happening, I simply put the probe on the chest, and this is what I see. So we continue looking for a pulse in this patient. How long do you think the search for the absence of pulse could have taken in this patient? It was definitely more than 10 seconds since they activated the code until I arrived there and we do this point-of-care ultrasound. So you're probably thinking, well, they should have started CPR before, and assuming they couldn't find a pulse. But it actually, in reality, sometimes providers simply don't know, and it takes some time to establish that point. So point-of-care ultrasound is a much more sensitive and reliable to allow for us to assess what's actually happening with the heart compared to a pulse check. Here's another example. This was a 45-year-old gentleman that was brought to our emergency department by EMS with ongoing chest compressions. We were told that he was in asystole. The rhythm strip looked just like this one. In the absence of a palpable pulse, the interpretation of this was PA, correct? So we put the probe in the chest, but this is what it shows. So this patient was really in fine ventricular fibrillation. And we know that a delay in diagnosis of ventricular fibrillation in any shockable rhythm significantly worsens the chances that you will actually achieve ROSC. So in this case, the patient was probably harmed by the fact that we defibrillated him late. On the other hand, we can enhance the specificity of our diagnosis with point-of-care ultrasound in terms of the confirmation of cardiac arrest. How many times have you had a patient brought in by EMS with ongoing chest compressions in whom maybe didn't need chest compressions? If you haven't been doing enough point-of-care ultrasound, maybe you haven't seen this situation enough. I don't think this video is playing. This is a patient that was brought in by our EMS group with ongoing chest compressions. On the monitor, the patient had an organized electrical activity with very, very low voltage, which was thought to be due to the obesity. On my first look in ultrasound, this is what I saw during the time that the patient was being connected to a monitor. So what do you think? Doesn't really look like what you would expect for someone with active chest compressions. Looking at the EMS rhythm strips, they all looked like this one, including the initial one when the CPR had been started in the field. So an arterial line was placed at that point at arrival and showed a blood pressure of 65/30. He had been 65/40. He had been, then we found out, got more information from the family and some friends, and found out that he was actually overdosing calcium channel blockers from a family member, and that the night before had been doing a lot of cocaine. So he had a mixed toxidrome and was really presenting in cardiogenic shock. Subsequently, the approach in this patient was completely different. We started him on pressor, and the approach was directed to search for a cause and support him until that heart got better. I'm sure you might be thinking at this point, well, I'm showing you zebras, right? This is uncommon. But this is just another case. Another patient that was brought in also with no palpable pulse. We put the probe, and this is what we saw in bedside ultrasound. Severe shock, EF roughly 10%. Again, this patient needed pressors and search for a cause, not the 1 milligram of epinephrine that we're usually giving cardiac arrest. So this leads to the topic, the term that I should introduce formally here, which is Pseudo PEA. I'm sure hopefully most of you have come across this term or are aware of this, but this is essentially a new entity that was described by Norm Pardis and other researchers in the resuscitation science field roughly 10 years ago. And it was basically the finding that many patients that we were calling PEA, that is, no palpable pulse with electrical activity seen on the monitor, were actually having cardiac activity. Problem is, when these definitions were defined, when we came up with these terms back many years ago, many decades ago, there was no point-of-care ultrasound on a systematic basis. And so they realized that there was a new entity that was a subset of the patients that actually had cardiac activity, some of them organized and actually generating some cardiac output that could be detected only with an invasive arterial blood pressure or with Doppler. 54 to 55% of the cases of the presenting PEAs are thought or have been found to be pseudo PEA or pseudo electromechanical dissociation, if you will. If you don't remember many other numbers from this lecture, this is the one number that I want you to remember. It's 55% of the patients, according to 3 studies, that are thought to be in PA are actually in pseudo PA. Why is that important? Two of the studies looked at the outcome, actually the three of the studies looked at the outcome of these patients. And invariably, in all three studies, the patients with pseudo PEA had significantly better chances of survival and better functional outcomes. I'm not going to go over detail of each of these trials, but you can look at them. You can look at them, and I can share with you these references. One is a pre-hospital study in Europe by PROGNOSTICATION. One is a study in the ICU in Sao Paulo in Brazil, roughly 50 patients. And the last one is the largest observational trial that we have in point-of-care ultrasound in cardiac arrest by Romolo Gaspari and many other authors, conducted in over 20 sites and concluded and published last year in Resuscitation. So we can, summarizing the diagnostic aspect, we can identify whether there's actually cardiac standstill, whether there is fine ventricular fibrillation that we should shock, or most importantly, probably, whether the patient is actually in pseudo PEA. It allows us to identify whether the patient is in pseudo PEA or in asystole, and again, it allows us to identify reversible etiologies. So let's jump into reversible etiologies. When you look at cardiac arrest protocols or protocols for the use of echocardiography in cardiac arrest in the literature, you come across with over a dozen of studies published mostly in Europe. So for the past decade, for some magic reason, each one of them has been published with an acronym with 4 letters. It seems like that was a requirement to publish a protocol in cardiac arrest. And so you have the FEAR, the CAUSE by Hernandez, the RUSH, the FEEL, and the FEAR by Breakowitz, German. The RUSH protocol described in part by Scott Weingart, Brett Nelson from our team. The EGLS described in Canada, the CORE. All these protocols are intended to be deployed for patients with either cardiac arrest or shock in undifferentiated hypertension. So if you look at these protocols, they're slightly different, but they're all essentially stepwise approaches where you're assessing for different things. Some of them are more complicated than others. The one that I would say it's most widely adopted because it was validated in Europe is the FEAR and the FEEL protocol. And that one essentially will ask you to classify the patient in these 4 types. A normal heart, a heart that is hypovolemic, a heart that has tamponade, a heart that looks like it's having a massive pulmonary embolism. Some are actually more complicated, and they ask you to look at the contractility, to look at the valves, to look at the RV, to look at whether the IVC is collapsing or not, to look at whether there's diastolic collapse of the RV or not. They ask you to look at the lungs and look for pneumonia. Liechtenstein, with his holistic protocol, very famous in Europe in the ICU setting, describes that you should do like 30 steps for the assessment of patient cardiac arrest. It includes scanning the legs for DVT, looking at the lungs for pneumonia, and a bunch of other things. So holistic, so that word that you should remember to characterize some of those protocols. I don't want to go over this, but I want to make you aware that there's a big problem, there's a big caveat with these protocols, and that is the fact that they were originally developed and intended to be protocols for the assessment of shock. And it's true that cardiac arrest is the ultimate form of shock. You could say that it's the most severe possible form of shock. But if you know anything about the physiology of cardiac arrest, the physiology and the hemodynamics during the arrest period are completely different than those seen in a patient in shock with an actual forward flow. So these protocols are not really designed to be deployed or used as intra-arrest protocols, and therefore you might be doing a lot of things that are really not oriented to identify the most important things, the highest yield things during cardiac arrest. Finally, what's the data behind these studies? The data is mostly observational studies. They've all been conducted in different settings, some pre-hospital, some in-hospital. But for the most part, these studies have been validated or have been conducted asking providers whether their findings on ultrasound changed their management. And that's what they reported and sort of how they validated the protocols. So they asked providers, if you did a point of care ultrasound and you saw a dilator V, did that change your management? Some patients, in some cases, that was what happened. And for example, they got lytics for suspected PEA, sorry. But we don't really know if that was indicated, if that change in management was appropriate. Nobody has really assessed that. Furthermore, if you think about some of these elements, the physiology behind it doesn't really make sense. And in fact, there is good data, some data, to support the idea that some of these concepts are actually wrong. Let's start with tamponade. So these are the 4 most important diagnoses that these protocols are asking you to sort of go after in the intra-arrest phase. Again, pulmonary embolism, hypovolemia, cardiac tamponade, and tension pneumothorax as potentially reversible causes. This is sort of the base for this myth, I believe, that some people say that point-of-care ultrasound can replace your HSNTs. That's really not the case, I don't think. It can enhance your ability to assess for some of those, but I don't think it can really replace it. Let's start with cardiac tamponade. This is probably the most important in the entity that we have most data about. The recent trial published last year, as I said, showed us that from their 700 patients, there were 34 patients found to have pericardial effusion. So 3.6% of the cohort. Of these 34 patients, 13 had pericardiocentesis. And from them, 15% had survived to discharge. So this is a very important number to remember. There's a 3.6% roughly of patients that you can expect to be able to diagnose with large pericardial effusion, potentially due to tamponade, in whom you should consider pericardiocentesis. And those patients will have 15% survival. That is a number that is incredibly high compared to the general survival rate for non-Jacobi rhythms, which is 1%, 1.5%, 1.2%, depending when you look at it. So that's what the money is. You should really be looking at, and this is, in my personal algorithm, this is what I'm looking for in the very first part of my scanning. How about tension pneumothorax? Any data? Not really. We have no idea what's the frequency. And that's because most of the studies have been performed looking at the heart. It's echocardiography. They haven't really looked at the lungs. So we really don't know what's the frequency. But it makes sense, right? It's a form of obstructive shock that we know that will lead into PA. There's plenty of case reports. So we know how to treat it, easy intervention, especially if it happens in someone young. This might be a totally reversible problem. What are you seeing here? Absence of lung sliding, correct? And what is this? Is this tension pneumothorax? Thumbs up? Yes or no? Maybe? Maybe. Good. Very good answer. So this is not tension pneumothorax. This is actually me holding a breath. So this is a pearl. In order to assess for tension pneumothorax during cardiac arrest, you need to be bagging the patient. If you're not ventilating, you're not going to have lung sliding. So during the pause, during the pulse check, you need to ventilate either with a valve mask or with your ventilator in order to effectively assess whether there's lung sliding. If not, chances are that you might be placing thoracostomies or placing chest tubes in patients that don't really need them. And I'm pretty sure this has been the case in my experience where I work. So that leads us to the third, which is hypovolemia. This is also appealing, right? Makes sense. Patient comes in, it's one of the H's, right? Hypovolemia, very treatable, right? Patient had a GI bleed for many days and and ended up hypovolemic from hemorrhage, or a week of diarrhea, severe dehydration, ended up going into arrest. So then this makes sense. The algorithms will ask you to look at the heart and see if the heart is empty, and then look at the IVC and see if the IVC is collapsing. And again, that's been taken from those studies that have validated in patients with shock, all comers, patients with cardiac arrest and shock as a one big population. And there's a big problem with this. The problem is that, first, there's no evidence showing that giving fluids during cardiac arrest is any good. Otherwise, it will be part of the therapy. I know that it's standard practice that many people simply give fluids during their cardiac arrest. They place the IV and they just start running fluids. The problem is, if you think about the pathophysiology of cardiac arrest, the most important determinant of your chances of achieving ROSC is the coronary perfusion pressure. And the coronary perfusion pressure is determined by the diastolic aortic pressure and the CVP, so the difference of these two factors. So we know that if we give fluids, we will increase the CVP. And if we increase the CVP, we will make that factor bigger, and we will probably harm the coronary perfusion pressure. So this is the rationale for many experts in the resuscitation field to advocate against giving fluids. So the one therapy that we would be, the one change in management that we would deploy or activate if we suspect that someone is hypovolemic intra-arrest, it's unclear if it's going to actually help the patients. So based on this, I've actually stopped simply empirically giving fluids in cardiac arrest. How about, not to mention that we have actually no idea what happens with the IVC during cardiac arrest. We have no idea what it really means to have a heart with the ventricles kissing each other versus a more dilated heart, the so-called empty or filled heart. It's all theory. We don't really know how to interpret that intra-arrest. As you know, hemodynamic changes will happen in across the different phases of cardiac arrest, and depending how long the downtime was, that will determine how much blood there is in the right side of the system, and that will determine how the heart looks, and definitely how the IVC. In addition to that, if you're ventilating a patient with passive pressure ventilation, that will definitely affect also how your IVC looks like. Finally, the fourth point is look for the presence of RV strain. RV dilation in intra-arrest is often said to be an indirect sign of PE. And based on this, in many of those studies, providers have given lytics. I'm not going to get into detail to analyze the role of lytics in cardiac arrest, but I just want to make you aware that we really don't have any data supporting the fact that dilated RV during cardiac arrest equals massive PE. In fact, we have pretty good data, animal data, showing that the RV normally increases its volume during cardiac arrest in the first few minutes to reach a peak and then starts coming down. Again, this relates with the pathophysiology and the no flow and low flow periods. That eventually the pooling of the blood in the venous system leads to an increase on the right-sided pressures that will eventually dilate the RV and the RA, and that would change depending on how soon we start chest compressions and we start to generate some forward flow. So those RV changes in the volume do not correlate with changes in the left ventricle. Again, this is a study performed in pigs looking at MRI during different times across the phases of the cardiac arrest. So summarizing again, we covered diagnostic approach. Let's go to prognostic. This is probably the most sort of famous application of point-of-care ultrasound in our specialty. About 10 years ago, Blivas and Fox published this study where they looked at patients coming in without hospital cardiac arrest and put the probe, and they showed that from 136 patients that had cardiac standstill at arrival, 0 of them survived to discharge from the hospital, regardless, actually to discharge from the emergency department, regardless of whether they were in PA or asystole. This information sort of changed last year with this large prospective protocol-driven trial conducted in Canada and United States and Canada. This study enrolled roughly 950 patients, and they looked at whether cardiac activity had the ability to predict ROSC and survival to admission and survival to discharge from the hospital. They also looked at multiple variables such as age, bystander CPR, whether the arrest was witnessed or not, and other factors. From all, the presence of cardiac activity at arrival had the strongest association with survival at any endpoint. So the presence of cardiac activity at arrival was stronger predictor of survival and at all endpoints more than any of the other variables they assessed, including end-tidal CO2 values, including whether patients had were old or young, whether patients had or not bystander CPR. In this case, the overall survival rate was 1.6%, so only 13 patients. So this is a study really looking at refractory cardiac arrest. They left out all the patients with ventricular fibrillation. They left out all the patients that recovered a pulse within the first 2 minutes. So they were really looking at the patients with the worst outcome. And what they found that was that 3.8% of the patients with cardiac activity at arrival survived, and the 3 patients, that is 0.6%, that had no cardiac activity at arrival also survived to discharge. So this was somewhat a practice game changer compared to the study that was published 10 years ago, in the sense that based on this evidence, and there's many limitations to the study, and you should have, if you haven't, a journal copy of this article. But the fact is, we know from this trial that certain patients that won't have cardiac activity on ultrasound at arrival might actually be able to be discharged from the hospital. You might ask, what was it, neurological function for those patients? That's a question that we don't have an answer for because it wasn't disclosed in that trial, but just something to be aware of. In the decision to call a code at arrival, you should probably consider this data. In general, we could say that the main prognostic role of ultrasound is to identify those patients in whom the resuscitation effort should not be continued. So while ultrasound can help us to identify those that have better chances of survival, probably the most important is to identify those in whom we should stop the resuscitation. Another important question is, what window should we use when we're doing point-of-care ultrasound and cardiac arrest? The data we have comes from this study in Europe. It's a pre-hospital study. And what they found was that the best window in this case was actually subcypher review. The next question you want to ask me is, what probe were they using in this protocol? They were using a curvilinear abdominal probe. And so that makes sense, right? But if you do have a cardiac probe, which is the case in most emergency departments, you should be using that to either obtain an apical 4-chamber review or a personal lung. If you're using a mechanical device, a Lucas or mechanical compression device, especially with a piston, you can actually access the personal lung axis view with the mechanical compression device on. Let's review some cases. There's a patient that arrived, PEA. This is the first look at the heart with ultrasound, doing the pulse check, large pericardial effusion. This patient did not need pericardicentesis to achieve ROSC by itself, but potentially you could see this during the active chest compressions, and if that's the case, you should consider pericardiocentesis based on the data that I just showed you. This is a patient that arrived, again, with no palpable pulse. As part of the standard, in all my resuscitations, many of my colleagues at Mount Sinai were placing INTRA-ARREST A lines at the beginning of the code to have that additional information to allow us to know what to do, identify these patients. So this is, again, Pseudo PEA. This actually looks more like severe shock. Another case, patient also no palpable pulse. This is the view of cardiac ultrasound. Final ventricular fibrillation. This patient also was shocked and got ROS. No palpable pulse. This is the view. So cardiac standstill. Very different scenarios, right? All of these cases, absence of palpable pulse, electroactivity would essentially be the same if we were not doing cardiac ultrasound. There's another case, person alone, not really cardiac standstill. The patient did not have a palpable pulse, but had organized cardiac activity. Again, it's another item to analyze, presence of lung sliding to assess for tension pneumothorax. Don't forget to ventilate. So we'll cover diagnostic, we'll cover prognostic value, point of care ultrasound during cardiac arrest. Let's look at what I think is one of the most important and most promising for the use of echo, which is quality enhancer. During CPR, we're really only generating 20 to 30% of the normal cardiac output values. So if you conducted high quality CPR, you will be delivering that percentage of the normal cardiac output. So we really don't have space, we don't have room to miss any of the cardiac output. We can't really afford to have inadequate chest compressions. The effect of CPR, according to the cardiac pump theory, is due to direct compression of the LV. Therefore, positioning of the hands or your mechanical CPR device is critically to actually generate systemic flow. So a critical question that we can't answer with point of care ultrasound is whether we're actually compressing the LV during resuscitation. There's plenty of data supporting the fact that this sort of one-size-fits-all recommendation from the American Heart Association and resuscitation guidelines that says we should compress in the mid-sternum or inter-nipple line doesn't really fit, doesn't really work for all patients. In over 40% of the cases, the structures that we're actually compressing is the LVOT, and in roughly 20% of the cases, we're actually compressing at the aortic root. I have confirmed this in our experience using transesophageal echo on a systematic basis for all of cardiac arrests. This is a case of ongoing CPR. This is a apical four-chamber view. As you can see here, the LV is not really being adequately compressed. Again, that correlates with the diastolic blood pressure we're seeing on the monitor thanks to the placement of an A line. It's another case in a side-cycle view that it's not ideal, but also can allow you to assess whether you're getting any compressions. Again, this is not validated. This is conceptual. This is supported by the observations using transesophageal echo on the same patients. So again, this is not something you should run and apply, but this is something that you should probably start looking at and considering for your next resuscitation. So in general, you could say we could use point of care ultrasound and echo to assess whether the compression is actually happening where it should be happening. But sometimes the images that we get with point of care echo transthoracic are really not that great. Sometimes they're like this one during the pulse checks. I'm sure you've had the case. In cases like that, many times the view and the information we're getting is just simply inadequate for proper decision making. So in those cases, we're left with a black box. And you should not be making decisions with a black box, especially now that you know that a significant number of the patients that are coming in and whom you can palpate a pulse actually have a cardiac activity. Some of them are actually in severe cardiogenic shock. You just can't detect it with your finger. So at Mount Sinai, following the work by Blyvas originally, and then Rob Arnfield, a former fellow of us, and others that have incorporated the use of TEA during cardiac arrest for every resuscitation to be able to obtain continuous real-time window to CPR. So this is a normal resuscitation with the transesophageal probe placed right after the intubation at the beginning of the code. That's a mid-esophageal four-chamber view that shows us essentially the same apical four-chamber view that you used to, but inverted. And you're seeing the compressions that are happening in this case, and the epinephrine is going in, as seen by those bubbles on the right atrium. This is a case that shows this is the same mid-esophageal view, but at a different plane that allows it to look at the LV and the outflow tract. This is exactly the same view as your as a parsing along, but seen in a different way. So this is the outflow tract. In this case, the patient had compressed the outflow tract throughout the entire cardiac cycle. That correlated with the diastolic blood pressure, roughly 14, and the end-tidal CO of 18. You know from resuscitation, from basic science data and resus, that if this CVP is roughly 8 or 10, the coronary perfusion pressure in that case was probably 4. So really insufficient, far below the 15 that we know we need to achieve ROSC. In this case, we optimize the compression side by displacing the hands towards the apex, freeing up the LVOT. That immediately improved the diastolic blood pressure and improved the end-tidal CO2. And after about a minute, the diastolic blood pressure was 24, the end-tidal had reached 31, and the patients went after achieve ROSC. This is a case of, again, ongoing chest compressions with transesophageal echo in place, showing the four-chamber view at the mid-esophagus. Again, it's another case where the LV, you can clearly see it's not being compressed optimally. This is a different case showing exactly the same situation. The bubbles, again, are from the epinephrine being pushed at that point. This is a patient that was considered to be in PEA. No palpable pulse, organized electrical activity in the monitor, unable to obtain any meaningful windows in transthoracic. This is what the transesophageal echo was showing. So not a normal heart, but not an asystolic heart. This is definitely not PEA. It's a pseudo PEA. As you can see here, there's what's called outer contrast. That essentially represents that turbulent flow that we see during cardiac arrest. That is a marker of inadequate cardiac output. Same patient. This is during the pulse check. And this is a practical aspect that I wanted to mention. You might be wondering, well, how complex is this? The answer to that is, as with any new tool, you need training. In this case, we do need to be aware of the risk of distracting ourselves by using a new tool or a new intervention, which doesn't have to be transesophageal echo, it can be just transthoracic echo. And if you're not really communicating with the team, if you don't have a system in place, you don't have a protocol on how you're going to do this practically, you do risk harming the patient by delaying other interventions like defibrillation or like analyzing the rhythm by, for example, trying to get to the place where you need to be with your machine, or you're blocking the view of the provider that is guiding the resuscitation and that is in charge of calling the rhythm. So in our case, they established a protocol where, depending on whether we're using this change from when we started using transesophageal echo, we're using two machines. One just dedicated for transesophageal echo, which is located on the left side, and a separate machine to do the vascular access, which is on the left side. So the provider that is placing the A line is located on the left side. The machine that is being used for transesophageal echo is on the right side. Immediately after the patient is intubated, the airway person moves. The patient is hooked up to a ventilator, and the patient, the person that is doing T, will get on the head of the bed. As you see here, the screen of the big machine is facing the team, so the entire team can be looking at that hardening as a continuous window to doing the ongoing resuscitation throughout the entire code. If you have only a transthoracic echo, you should be probably placing the machine on the left side to be scanning from the left side of the patient. So to conclude, the things that I want to leave you with are these three main interventions. The next time that you approach a resuscitation, that you use ultrasound, the things that are really important, the things where the money is, are the assessment of cardiac tamponade, the assessment of tension pneumothorax, and probably the most important is whether your compressions are actually being effective. With that, I thank you for your attention.